Then he tells the stories how they got there. It's just a different caller. So funny.
I'm gonna have to look into it more.
Yeah, he's a funny dude.
Why can we didn't put your squad number on this? Squad. Squad. What were you? Squad 2? Squad 6?
Oh, yeah. Squad 1.
Yeah. Squad 1.
Squad 1.
Is this everyone?
Yep.
Kind of, yes.
52 or 54 is joining us remotely.
I think I got them.
Make sure you talk to them like they're real people.
Hi, 54. I know you're there watching over us. So, obviously, we have been, everyone here has done some form of pediatric training or a lot of pediatric training. So this is kind of a mixture of refresher, kind of teach some new things to maybe some of the newer guys who haven't seen stuff, and then kind of hit on the important things that we could all work on as a department and as individuals. So when you go on a pediatric call, what is the first thing that goes through your head? Oh shit.
She said
right?
it, we thought it. Yep.
Right?
Appreciate the honesty.
So going back to your basic EMT paramedic school class, first day of pediatrics, what is the first thing they teach you about pediatric assessments?
Their parents.
There's parents. What else? What about our assessments? How do we look, like you walk into the door, you see that child, what goes through your head?
Sick or not sick?
Sick or not sick?
Are they crying?
Are they crying, right? The triangle, right? So circulation, work breathing, appearance. You should walk through that door and tell whether that kid is sick or not sick. Are we gonna stay and play or load and go? So this should go through everyone's mind every time we go walk through the door, we see that child on any pediatric call. But peds range for so much, right? So we could have a neonate to 17, 18. If they're under 18, consider a pediatric. Does that change our treatment? Sure, but they're still considered pediatric. So things that we could also work on is kind of, and this is a lot easier for parents because they've seen this and they've gone through it, but it's a little bit harder for us that aren't parents. It's kind of like their development status. What is a normal behavior for this child? And who's our greatest resource for that? Parent. Kind of look at your cards. Like, okay, let's see, how old is he? 6 months? Okay, 6 months. You can recognize caregivers. You can make eye contact, So always communicate with the parents to know what is normal, what's not normal. And obviously, if this kid is sick, we're not going to really mess around with what's normal, what's not normal, because we're going to control our scene and that patient and what's best for them. So it's just kind of like infant, this is toddler development. So it's just really interesting just how fast a child can change in the first 2 years from being born to now they can walk and talk 100 words or something like that.
When do they start talking back?
3.
I'm going to phone a friend for that. So we've done our triangle, right? You're trying to do your assessment on this kid. What's the first thing you're doing? Going back to the basics. Airway, A, B, C, D, right? And E, but I didn't really put E in here. So airway, does this kid have stridor that you're hearing through the door? Does he have wheezing? Is he snoring? Does he have a good airway? And what are we going to do for this right out of the gate? You walk in, your kid's snoring.
Wake them up.
Reposition.
Reposition, wake him up.
That's why I snore.
Let's see, how did you make that sound before?
It's understandable. And, going back, BLS Airways. Doesn't matter if you're a basic, you're an advanced, or you're a medic. Basic airways save lives. Doesn't matter if you threw the tube, doesn't matter if you threw a supraglottic. At the end of the day, good BVM skills is what's going to save your patient. And the big thing about this is don't hyperventilate your patients. At the end of the day, we're all going to be super anxious any kid we go on, especially if they're having trouble breathing. You pull that BVM out, you got something wrong if you're not freaking out. And what do we tend to do when we freak out?
We don't think clearly.
Hyperventilate.
We hyperventilate, we don't think clearly. So in the back of your head, try to be like, let's not hyperventilate this kid. You know, let's not send their end tidal to 15. So this is just some airway placements for OPAs, NPAs. I know we go through PALS, and on that little scale where you throw an OPA and an NPA, you look at whatever's there and you throw it in, right? But we gotta make sure we really measure. Because if you throw the wrong NPA in, it's either not gonna work or you're gonna cause damage. If you throw the wrong OPA in, same thing, it's either not gonna work or you're gonna cause damage. Good BVM skills. Who wants to volunteer? Gavin.
Get it back, maybe.
Yep, come on. Yep, come on out, lay on the table.
Okay, so wait, let's do it.
So you walk in, you need to bag this kid. He's
Okay.
not doing well. How are you gonna bag him?
Gonna get something, pat under the shoulders.
Why?
Just open up that airway a little bit, right? Their head's really big, so it could be just like causing some constriction of the airway, right? So we're gonna position that airway, and I'm just gonna start bagging, so make sure that we appropriately size our mask, my PEEP's where I want it to be. I'm gonna perform my C-clamp and not hyperventilate.
Okay. Would you want a second person with you?
Yes, that would be ideal, right?
What would you? You're in charge of airway.
So if I'm in
So
charge
you
of
have
airway,
a second person come up.
Cool.
What are you gonna tell them?
so if I have my second person come up, Carly. Hi, Carly. We're bagging this kid. Yay, Carly. So what I'm gonna have Carly do is I'm gonna have her manage my seal. So I'm gonna have Carly take both of her hands, really bring that head up more into the mask rather than putting that mask down on that kid, right? We don't want to cause a vagal response. And then I'm just gonna manage the volume that I'm giving the kid. So we're looking for good chest rise and fall. After maybe a minute or two, we're gonna start looking for improved color, good bag compliance, that sort of thing. So
Okay. So you're bagging this kid. He's sounding at 88%. You're bagging 100% O2. What's something else we could do?
this is when we'd start thinking about getting a more advanced airway.
Okay. An
So,
advanced airway. Anything else?
I see a 1.5 size eye gel.
Okay.
That might be something we could consider.
No, there's BLS ones right here.
Yeah, we got BLS ones too.
I mean, I think given the circumstance, 88 is pretty sweet.
That's what I was thinking. There's so much more to the story, right? What's stressful,
Yeah, right. Like what's causing
Even
this? Right?
sick, right?
Yeah.
These things, the history are gonna help us.
There's a lot that goes into it, right?
Is your SpO2 spot the right spot?
Yeah, right.
Yeah. Keep moving, keep finding the number you like. Yeah.
So if we're 88%, right? But we'd also be looking at like skin condition too, right? Like how cyanotic are they? Are they peaking up at all? Are they super pale? We should be checking a pulse rate at this point as well. So we're thinking about maybe doing chest compressions if that's SpO2 is not popping up. So
Yeah. Good job.
What's your chest compression cutoff?
What heart rate would you start compression?
60 for this size. Yep.
Good job, yeah. So that's what we should be going through anytime we're going through pediatrics, especially BVM and airways. Is talk to yourself, talk to your partner. If you can get 2 people on that airway, and 80% of the time, we probably can, especially on a kid. Because most of the time he's so small, not all 5 people are going to be around him. You can be like, hey, you're not doing anything, can you help me on this airway? I guarantee some people will be more than willing to help on an airway. And then different techniques. Are you doing the CE? Are you doing the TE? Okay? I like the TE mostly. For kids, you mostly want to try and do a jaw thrust over a head tilt. You're going to open that airway a little bit better.
With the jaw thrust too specifically, if you do it good enough, it really fucking hurts. So if you're doing that and you're not getting a response from the baby, that's where you're like starting to like escalate. Like, all right, they're not doing well. No different than an adult, right? You do a good jaw thrust and they don't respond, they're like, all right, like, they're sick. Like, that's a pretty good, you can deliver, you can open the airway perfect, and then you can also deliver a little bit of response. And if that response doesn't get what you want, then that's how you know you need to step it up a little bit, or they're sicker than you thought, or like that kind of stuff. Because as if you're given that little bit of pain and they're not responding.
Yeah. Do we
Don't
like
torture them, but
Yeah. Do we like crying in kids? We like crying in kids to a point. So as Gavin explained, different head positions to open that airway up. And as you can see, just laying flat with nothing, you can see how his head's still kinked forward. Same thing if he puts a towel under the head, and then if you put it under the shoulders, he's got more of that sniffing position, as we all know, right? What's first, we always, a lot of the stuff we've heard over and over and over again, right? Put towels under the shoulders, put towels under their shoulders. So a lot of this is just kind of reiterating. Breathing. What are some things you're going to do for your patient to cross off that B in your ABCs? Strip them. What else? Are we going to listen to lung sounds? Are we going to count respirations? 18, right? Yeah. Perfect, right? Make sure we always count respirations, especially in kids. Okay? End tidal, if we're bagging, or if we have an advanced airway in. Or you can even put it up to the nasal cannula if you throw them on oxygen. Okay? Pulse ox, do they have retractions? Do they have nasal flaring? Are they in a position, like a tripod position if it's an older kid, or do they have that sniffing position? Okay? These are things that we have to be looking for in all of our children. And then what are we going to do for this? Oxygen.
We'll be aggressive.
Be aggressive. We have to be aggressive in kids, right? Because we all have seen the charts of how fast kids deoxygenate versus adults. What about humidified oxygen? Is that a thing? Do we have humidified oxygen? Just sits up in the cabinet and collects dust and expires. Humidified oxygen can make such a huge difference in kids. Even if your transport's 5 minutes. Just throw it on there. Doesn't hurt, right?
so what else can we use if we don't have dehumidified oxygen? Like in the normal oxygen.
Oh, nebulous.
Swag it. There's a bunch of different ways you can accomplish the goal.
Yeah. Nebulized medications. Is this kid wheezing? Does he have stridor? What medications are we going to nebulize?
Racemic epi.
Racemic epi,
Buterol.
albuterol,
Atrovent.
Atrovent.
Buterol.
Yeah, if you throw albuterol on, are you going to throw Atrovent on in with it?
Not initially.
Yes, depends.
Less than a year.
Yeah. There's some kids that you don't give it to.
Yeah. So that's another thing. Like, can we give Atrovent? Should we give Atrovent? Or are we just going to keep doing nebulized albuterol? If it's an asthma kid, you've given multiple albuterol treatments, you're still hearing wheezing, this kid's still struggling. What else can we do for that kid?
IM epi.
IM epi. What's the last one? Mag. That orange medication that sits in the bag and it's like, oh, it's just mag. Just mag. What about suctioning? Your RSV kids. Who knows how to suction the nose? Could you guys do it? What about the mouth? Kid's awake. He's got snot coming out. He's drooling. You guys would be like, nah, we'll let the hospital do it. Learn how to suction. You should suction your kids if you need it because it will make such a huge difference in their breathing and their outcomes. So learn how to suction. Use your French catheters. Usually it's an 8. Measure it. Tip of the nose to the earlobe. If it's your nose, throw that in there. Twist it as you pull out and suction. And the kid's probably not going to like it, but at the end of the day, How many RTs have you guys seen on your clinicals hold the kid down? Like they just hold that head down, they stick that French catheter in. They just it's treatments we have to be willing to do that help our patient. Instead of being like, nah, I'm gonna let the hospital do it. What about PEEP? Could PEEP make a difference? PEEP can make a big difference. Not a lot of PEEP, it's not, cause of pneumo, but. Oh, does this kid have trauma? Do we walk in there, we strip that kid open, and he's got bruises? We ask mom, like, hey, has he had any trauma lately? No, I don't know. He's been at daycare. Okay? This is something we have to keep in the back of their head. Maybe this kid's had some trauma. If he's got bruises, he's not acting right. So that's another question we should be asking. When we listen to lung sounds, this is just a diagram on how to listen, just where placement is on children. Make sure you really listen to lung sounds. Clear and by that all right. We've all seen a chart similar to this on how kids desaturate. That's the yellow line. Compared to a moderately ill adult or a normal adult. It's a huge difference. So if this kid's struggling to breathe, we really have less than 3 minutes until this kid's gonna start desatting like crazy. Circulation. How's this kid look skin-wise? Is he pink? Is he dry? Is he blue? Does he have cyanosis around the lips? And then what are we gonna do? We're going to take a blood pressure on him. He looks fine. He's good. So we do a blood pressure. How are we going to know if it's normal? Pull out your Broslow. Pull your little card out. Good things to do. We should always go back to the 70 plus 2 times their age. And it should be above that. Because below that, they're hypotensive. If they're under 1 month, 60, okay? So right around 70 for a systolic if they're up from a month to a year, and then the 70 plus 2 times their age, up to 10 years, and over 10, 90. And then chest compressions, right? This kid's not doing well, his heart rate's at 60. Are we gonna do CPR? Right at 60 and 58. He's at 58. We're gonna do CPR?
They look like crap, yeah.
Yeah, we're gonna do CPR, right? Bag that kid, get him good oxygenated, recheck your heart rate, see if it's came up. Continue CPR if it hasn't. And then disability. Goes back to this stay and play, load and go, AVPU, or GCS. We do GCS on kids.
Yes.
Yeah, there is a card that's specifically for GCS in kids. So get a good mental status on that kid. Let's get temperatures, blood sugars. Where's a good place to get a blood sugar on a kid?
Heel.
Their heel. Bottom of the heel or to the side? Just the side. When I did phlebotomy, we had to go in and do the little paper test on kids, on the neonates. Do the little drops of blood on the paper. And we had a phlebotomist who was sticking the bottom of the heel, and the pediatrician lost his mind. Said it causes a whole bunch of health problems in the future for that kid. Didn't know that. How are his pupils? Does he have pain? How's his posture? Is this upper airway or lower airway? And what are some things that we can do and see to tell if it's upper or lower?
Put your bell on their cheek. If you hear it really good on their cheek, then you know it's upper.
Yeah?
Because they're small enough, you can hear it. It can resonate. Other than that, it's really loud on their cheek. That's how you count.
Yeah, that's a great thing. I never even know that about that. So that's
You
one
on
thing.
adults too.
That's one way. And listen to lung sounds. Kind of have a good understanding of different conditions that could be going on. RSV, pneumonia, pneumothorax. Does he have croup? Does he have glottitis? Does he have bronchiolitis? You know, go through the pneumonia. There's so many different, keep in the back of your head, like, what is going on with this kid? If this kid's got asthma and you don't hear lung sounds, is that good or bad? It's very bad. Very bad. We hear wheezing and he's got asthma, is that good or bad?
Better.
We like it a lot more.
Check which way your bell is.
Yeah. Yeah,
Sounds absent.
yeah. Make sure, don't, if you ask Luke, Emily, Captain Emily, don't tap it.
Well, don't tap it with it all in your ear.
So, go back and kind of research different conditions that you have. You're like, oh, you go on a BLS transfer, kid's going up to McKay. You know, he's on 0.5 liters of oxygen, and he's got bronchiolitis. You're like, I don't really know a lot about bronchiolitis. Like, I'm going to do some research on bronchiolitis so that I can help my patients if I have a kid that has similar symptoms. What do they do? What's the treatment plan for this kid? Glucose is a big thing for kids. We give D50 on kids, right? What do we give for dextrose? D10? D25 if they're a little older. Pain management. Are we going to give pain meds to a kid? He's breathing fine. He's oxygenating fine. What's your dose for fentanyl? 1 mic per kilo. We give it intranasal. Yeah, you can give fentanyl intranasal. If you're like, I don't really, this kid doesn't need an IV, but he's in a lot of pain. Or I don't feel comfortable starting an IV. Understand your kid's anatomy, or just pediatrics anatomy in general. Their head's bigger, their tongue is bigger, their larynx is more anterior, the epiglottis is more U-shaped, floppy. Their trachea is shorter than adults. So for your medics, if you're intubating a kid, it's more likely throw it in the right maintenance stem. Their airway diameter is smaller. The residual lung capacity is smaller. That's why they desat so fast. Just keep this in the back of your head. Like when you're doing a procedure, be like, if you're intubating a kid, you're like, you throw it in, you're like, oh, that might have been a little too deep. You throw your eye gel in, we're getting good compliance, but we need to watch our bagging. Maybe we're bagging too much. Let's cut back on the milliliters that we're bagging. And then different conditions. What are we going to see in kids? Because there's so many. Throw some out there. What are we going to see?
Croup, pneumonia.
Cystic fibrosis.
Cystic fibrosis. Are we going to see kids on vents at home?
You can.
Yeah, there's a kid up at 54's area who's on a vent. What are we going to do? You walk in and the kid's on a vent. I don't know.
Relax, go to bag.
Yeah,
Okay, right.
you know, it's okay. It's fine he's on a vent. He's at home. A doctor obviously thought he is fine enough to go home. Okay? But now we need to troubleshoot it. Mom, how does this machine work? How do you do it? Okay? Hey, this kid, he's not doing well. He's purple and he's on his vent.
Bagging.
Bag him.
Figure it out while you're
Suction.
bagging.
Dope.
Love it. Dope. Go for an ET tube. Does it work for trachs? Sure does. Who feels comfortable suctioning a trach now? Yeah, who did clinicals at the snot farm? Yeah, amazing. Super sad to go there, but I learned so much. I learned how to suction trachs, which is such a huge skill for me. Like, I loved it. To where I
Walk us
feel...
through that.
Huh?
Walk us through it.
Well, you just need to suction this kid or adult or whatever, and let's say they're awake, okay? We're gonna pull that vent off. We're gonna squeeze a little bit of saline in there. You throw your French catheter in. Usually they'll start to kind of gag on it almost. It's like a gag reflex. Then we're gonna close the suction, kind of twist as you slowly pull out.
Would we see inline suctioning at home vents?
Good. Yeah, I would think so. The parents suction at home all the time, so that they have to have the equipment for it.
The kid in 54's area has it.
Does he?
Yep.
So yeah, use the inline suction. Or mom, hey, do you mind suctioning him real quick? If you're like, I don't want to suction this kid. Hey mom, do you mind suctioning him? When was the last time he was suctioned? How often does he need suctioning? Oh, yeah, he needs it usually every 30 minutes. He hasn't had it for a while. I can't remember. It's been a while. Okay, do you mind if you suction him real quick? He's still struggling. You suctioned, he is still struggling. Pull that vent off, go to a BVM. Simple as that.
One thing I feel like, and not that that can't happen, but it seems like these parents are pretty prepared.
For sure.
So they've done everything like that. They've troubleshooted to a point. They're now past their moment of capability. So for us, that should tell us something, right? You've had a parent that's been with a kid that's been venting for years. Well, now suddenly they're calling for help. That should kind of raise your index of suspicion quite a bit, because they're probably pretty damn good at handling that vent and running into issues with it. Something's happened to that moment, just like diabetics, we go on, right? Just up until they can't handle it, now they expect us to come in and fix the problem. So it's okay to go to our BLS stuff to get our feet underneath us, right? Take that tactical pause, we're ventilating, oxygenating, cool, deep breath, get history from mom, but just know that typically it's past their capability level,
Right.
right? And that should kind of spike us a little bit.
Yeah, no, 100%.
One thing with suctioning is we need to make sure that we try to keep that as sterile as possible. We do a really horrible job at that. So just remember, you're introducing a foreign body into their respiratory system. So like, you don't need to pull out sterile gloves, but there's a reason why the stuff from the hospital stays in that little like
Aseptic.
yeah, like the aseptic thing. So we just want to make sure that you're not just pulling something out, raw dogging it, and just sending it down, and then hoping that they.
Okay, Mitch, no round up.
Yeah, that is quickly.
We still talked about Airway.
Touching it with your dirty gloves, that dog shit on it.
There it is. There it is.
That's what you were going for.
Yeah. Keep it sterile.
There's the best.
Keep it sterile as possible. Tried it?
I think I forgot to put raw dog in this. It will be.
You know what I meant.
You
know what I meant.
Is it on the test?
It's on the written now.
Is that one word?
Not on the city pipeline, please.
I think it's hyphenated.
Yeah.
But like, you go up to that kid in 54's area, and mom's like, he's not doing well, and you're like, vent. Like, she's messing with the vent. She's like, I think something's not right, or like, I don't know what's going on. He's just not doing well, and you get so focused on that vent. You're going to primary children's, and you're like, we've done our dope, we've suctioned, we got good airway compliance, and you call primaries, and they go, what's his temp? Oh, it's at 103. Shit. Is he septic? He's got a trach. Is he more susceptible to infections with a trach? 100%. You're like, we missed it. We were so focused on that vent, we completely missed it. Or you check a sugar. How many times have you called the hospital and you're like, he's having a stroke, code purple, get the CT ready. And they're like, what's his blood sugar?
Please don't be 50, please don't be 50.
I had one, we wheeled the guy in. They didn't ask over the phone. We wheeled him in, and they're like, we're going to check a sugar real quick before we go to CT. Oh, shit, we didn't check one. 30.
Son of shit.
Sorry, doc, we totally missed that. But at least he's doing fine. The good news is he's not having a stroke.
You're welcome.
You're one. So we hear with kids, respiratory distress, respiratory failure. What's the difference? You get a brand new guy on your crew who's like, I want to learn, but I've been reading this chapter about pediatrics and I just don't get the difference between distress and failure. What's the borderline that crosses that? Anyone?
Respiratory rate and work breathing.
Respiratory rate, work of breathing, to the point where that kid cannot oxygenate for himself and he has completely used his stores trying to breathe. He is in failure. If you walk in through the door and you hear wheezing, he's hyperventilating. Is he in distress? Yes. He's in distress. Now he's desatting. He's not breathing as fast now. That kid's in failure. Either the phone call was too late or we didn't act aggressive enough. What about anaphylaxis? Not a big airway thing? Hey mom, has he had a reaction like this before? No, he's never had one. You know, you go on a newborn that they just switched from breast milk to formula. How many times has he had the formula? 2 times. This is his 2nd or 3rd time he's had it. Now he's got hives. He's not doing so well. He might be allergic to the formula.
Even just something as simple as them spitting up a bunch, you get an infection.
Yeah. A foreign body. You know, you always see the toys where it's like, keep away from children. You're like, how does a kid stick a toy soldier in his mouth this size of my freaking pointer finger? Drownings. Is that a big airway one? Does that change our mindset with airway? Airway, as we've all heard before, is the #1 thing in kids. So we've seen pictures similar to this, and this kind of opened my eyes when I went through the difficult airway course. If you've done intubations, you've done mannequins, you throw that blade in there, what does those kids' vocal cords look like? They look like a full-size adult. And then you look at pictures, like if I had the intubated kid, first thing I got my medic, I would have expected to see adult vocal cords. And like, oh shit, those aren't big. So now we're able to kind of see the progression of growing in a kid's airway. More of the anatomy. Kids' airway is more anterior. The epiglottis, the head, the tongue, everything's just different. So as you listen, this is a video, just a short one, but as you listen to this kid, just listen to what you hear, what you see, and like, what am I going to do for this kid?
Take time, little one.
First thing out of the gate, sick or not sick?
Sick. Yeah, heading there.
Yeah, he's getting there, but your initial impression is like, this kid looks pretty good. His skin's good, he's got no cyanosis, and his skin's pink, he's doing okay. The wheezing, you know, I don't really love that wheezing. Is he in distress?
Yes.
Yes.
Getting there.
Yeah, I'd say he's in distress. Like, we should probably do something for this kid. Let's give him a treatment. Let's give him an albuterol treatment. Anything else you guys would do for that kid? Just throwing it out there. Positioning.
Just pull by, put him in a car seat,
Yeah,
get his head up a little bit.
the car seat. So this is another one.
your kid's sick, but can I take a video of this?
Yeah, first thing we're gonna do is watch him suffer.
Yeah. I always love that. We're gonna film this, Mom, real quick. Kid's been working out, he's got some hell abs.
Fluffy pancake.
Yeah. What did you guys see?
Accessory muscle use.
Accessory muscle use. If you take you see that kid, you're like, you know, he doesn't look great, you know, he looks like he's sick. You know, hey mom, can we take his shirt off? And you see that, like, oh shit. This kid's obviously struggling to breathe. Probably get him off the floor. Probably not helping that he's laying supine on the floor.
What are those puffy pancake things you got up there?
You know, I think that, let's look it up.
Another note. Let's talk about
Pretty
those.
good, actually.
This is a guest network, okay?
Uh-huh.
This is not mine.
Yeah, what's that gaming thing you're like?
Those are Japanese
It's cool.
things.
It's my nephew's, okay?
We knew if it says on it said autism or no
Oh, I already knew the answer to that one. My mom told me years ago.
You're special. You're different.
I know.
This kid's sick.
When he came out the
What?
first time and saw a big bus, he was like, did you see the size of that bus? That thing was huge.
Like, go pick up.
I didn't know they had long buses until I was in high
It's
school.
way bigger than the bus I ride.
Obviously, this kid looks sick, right?
Non-games,
Oh, jeez.
posture protection,
That sounds.
non-invasive.
That doesn't break me.
That's heartbreaking.
It's a freshie.
Ugh.
So sad.
Truly sad.
You gotta make us watch that.
Because I'm evil. Because I have autism.
This is what I do at home.
Yeah. Kid's sick, right? He's not breathing well. He's grunting. He needs to go in.
I think a big thing with that one, because I mean, I'm assuming that was probably a post-delivery pretty quick, is we have a really good job of making those ambulances comfortable for us. And we cause those, you know, he hasn't had to regulate his temperature ever till he comes out. And he's probably wet, dry, or wet, all that kind of stuff. So we want to make sure that that ambulance is, like, we're sweating bullets. Maybe put a heat pack on with a towel, try to keep them warm. Because you throw a baby into a 72-degree environment when it's used to 98 point something, like it's just cause a little bit of shock for them.
Yeah. Crank that heat up. And not just in kids, you know. Elderly patients, septic patients, any patient in shock. I turned up the heat in the ambulance the other day, and I won't say who it was, but one of my EMTs was like, oh my god, it's hot. Can you turn that off? No. Like, we'll be fine.
Maybe don't refer to them as your EMTs.
My partner in crime.
1 out of 4.
So we know a lot of conditions, right? So this kind of just goes into different conditions that we're going to see. Kind of goes a little bit more in depth on what's really going on. So kid's got, we know, he's got asthma. We know what asthma is. Some of us here probably have asthma.
It ain't easy being wheezy, you know what I mean?
Oh, yeah, is that what it is?
So,
Would you like a meter dose inhaler? I got a spare. Anybody need a spare?
I'll take a puff.
Shit works.
Pass it around.
That's adulting at its finest.
take a few puffs here and there. So usually occurs in the ages of 5 to 17. If he's under 5 and he's got really bad wheezes, be like, is it really asthma? Could, I guess it could be. No, I'm not a doctor. Or if you have a kid in his teens, do you have an inhaler? No, I don't have an inhaler. Or yeah, I got it and I left it at home. My mom does it for me. She didn't pack it for me. Could be allergen triggered. Different treatments, ABCs, nebulized medications, oxygen. Hospitals will do steroids. Maybe one day we could do steroids here. Just throwing that out there. If it gets really bad, mag. Croup. We all hear it. We walk in, hear that barking cough, right? What can we do for that kid?
Cool air.
Funny you mentioned that. Doing some research on this, I found a new study that came out that said that cold air and nebulized saline have little to no effect on croup patients.
All I know is with my kiddos, and even kids we've walked out of week care with them, they sound like shit in a hot environment. The second they get that cool air, that bark gut starts going away, they start feeling better, it's crazy.
Yeah, I mean, just a little study I read. I don't have kids.
Your study's stupid.
I remember, yeah, apparently.
My anecdotal study
Yeah.
confirmed is clearly better.
Yeah. I remember seeing the rescue, Layton's first rescue come to my house for me. Have my old man jump out, take me to week care.
How was his walk?
Took
Can
you to
you
week
show
care?
us how he
Yeah,
was
took me to
walking?
week care.
He's like, yeah.
Besides the point.
Dad doesn't love you, I don't know how to tell you this.
I mean, the younger brother went to primaries,
And you got to go.
and I gotta go to week care.
He's just the middle kid, he can go to week care.
He's fine.
Carson was told to tough it out, and generally you're not sick.
Right?
Get up.
They at least took me in, gave me that good amoxicillin. Different treatments. Try to keep this kid calm. You can take him out. Have mom take him outside, wrap him up. You can give the nebulized saline. If he's got really bad stridor, we can give the racemic epi. Suctioning. Bronchiolitis, usually a viral infection. Not everything's bacterial. As some patients go in, they're like, I just need an antibiotic. Like, man, you have COVID. It's not gonna do anything. Wheezing, inspiratory crackles will be the first signs of bronchiolitis. A lot of our treatments don't really change here for some of these conditions. A lot of them, they just have to kind of ride through it, you know, especially the viral ones. So we're just gonna keep comfort measures. Have mom bring his little iPad out and have him watch whatever show. Pneumonia. I feel like I've seen a lot more pneumonia patients get transferred in kids. At least on my shift, I've noticed a lot of pneumonia kids that were transferring to McKay or primaries. I think it's kind of interesting. But it's the #1 case of mortality in children worldwide. We listen to lung sounds, they're junky. He's got a temp. Has he been sick recently? Yeah, he's been sick for like 2 weeks.
What's productive dough?
Shoot, if you have to ask, you've never had.
Oh, you know, typo.
It rises, that's what makes those pancakes.
Pancakes.
Yeah.
All coming full circle.
You see what I type and what I type what I'm thinking. I
Damn
was
right.
thinking about dough and
I
pancakes.
gotcha.
Is it though or dough?
Cough. I meant to write cough.
We knew.
I know.
We said.
Feel like we know. How's this kid been feeding? Okay. No, like he hasn't been feeding very well. Is he lethargic? Is he really irritable? Things to look out for. Look for signs of sepsis in these kids, or just any kid who's just not doing well. Let's throw a temp. Let's get a temp on him. He's kind of hypotensive. We did the 70 plus 2 times his age. It's below that. He's really tacky. He might be septic. And it talks about, I think I skipped over it, but I threw in vasopressors. Can we do vasopressors for kids?
After we fluid resuscitate.
After fluid resuscitation, if we have fluids.
We got plenty of 10cc syringes.
Plenty.
Send it.
That's all we need. A few 10cc syringes. Get that 20 mil per kilo bolus. What about push dose epi? We do it all the time for adults, right? Could we do it for a kid?
Yes.
What's our dose for push-dose epi in kids?
0.01 mics per kilo.
1 mic per kilo, up to the minimum adult dose, which is 10. So you got a 10 kilo kid, he's getting 10. I actually had a question when I did my board with Dr. O. That was the question he asked me. And he actually did, I said we could look at push dose epi. And he's like, yeah, I don't know what the dose is for it. Let's look it up. So me and Dr. O looked it up and we researched it. Yeah, and he loved it. He's like, yeah, you could definitely do it. So I thought that was pretty cool. Cystic fibrosis. This is going to be your at-home kids mostly who are on vents. Terrible. I don't like cystic fibrosis. It's awful to see. You go down the South Davis community and you got a bunch of kids who have it. But this is huge, talking to parents like we discussed. Don't get so focused on one thing, the vent. Or maybe they're not on a vent, but they still have a trach. These kids are very susceptible to sepsis as well. So we talked about trach management, so we kind of got ahead. So anyone wants to throw in anything else with trachs we didn't cover? Suctioning.
Don't lean over the top of their trach when after you suction, because if they cough, you're going to take it right.
Yeah. If you get some glasses if you're gonna suction. Put a mask on and get some glasses if you're gonna suction a trach.
There is a possibility with it being obstructed, so you want to be very, very careful when you're doing it, and make sure you landmark if you try to remove a trach, or so that's another deal. When you're checking your chest rise and fall, if you're not getting chest rise and fall, don't be hesitant to, if you do pull it, just be very careful because you might lose it. But you also can intubate trach patients too. You just gotta intubate them and then go past their trach hole.
Yep. So if you absolutely had to replace the trach with an ET2,
Clearly forgotten. You knew what I meant. You knew what I meant.
So suctioning.
I did not say that.
You were asking what the name of the hole was.
You're losing us, Garrett.
I know.
Get us back on track before I get
I
fired.
know. We're almost done here. We're almost done, okay?
Not good enough.
So I really have like 2 more slides left. So I did some more research nationally. There are tons of different research out there, and they have so many different results. But one that I came across was one that they did in LA and Orange County. And another one I came across, they observed 1,005 agencies on innovations in advanced airways. And they found that there was one pediatric intubation that took almost 2,200 calls. Very few. Had a 66% first-time pass rate for ETs, with a 97% overall. So second, third attempt. For adults, that's the LA one for adults. Was 78.8%. First attempt was 68. And then I got some image trend statistics, and it's very vague. But since image trend first started, so I guessed around maybe 3 years. I can't remember. I couldn't remember how long we've had image trend. 5 or something like that. But since image trend first started, Layton has had 137 total innovations.
Pediatrics or just?
That is total. I couldn't narrow it down. Or my image trend guys couldn't narrow it down, so they just gave me the total. We have a 76 overall success rate here at Layton. Could we do better?
Yeah.
Especially in kids?
Did you, I'm
curious, did you research, what would that be, 24% why they were unsuccessful?
It was hard enough just to get our innovations.
So it sounds like you have image trained guys.
You do
I
have
do have. Well, they're the same image train guys you have.
Well, they also your EMT.
No, they're my medics.
They're his chiefs.
So this was something I was going to follow up with Josh about. So he's the one that pulled all this, and he said he thinks he got it. So it kind of made him more curious to see if we could pull up more. But he pretty much was able to get the basics, how many innovations we've had, and whether they were successful or not. And I kind of had trouble figuring out like why it was missed or why it was like what went well, what didn't go well. So he said he had to look more into that. But overall, those are just hard number statistics. Unsure of why they were not unsuccessful. So we're sitting about 76% success rate overall. I was actually very surprised. I thought this was just within the last year. But that's since Image Trend first started. So that kind of surprised me. I thought we were getting more. Or I thought we had more. But just conclusion, go back, always train on pediatrics. Make it a specific training for your crews, for your new guys. I feel like we do it very well for adults. And then there are some guys do very well in pediatrics. Like everyone knows, we all have specialties that we're very good at and specialties we could definitely work on. Hit those guys up that have worked at primaries. They've worked on pediatric floors. They've done hospital. They've worked in a hospital and seen a lot of kids. Recognize signs and symptoms of your age groups. What's normal for this kid or what's not so normal, and keep resources handy. Like, where's our Broslo tape? Yeah. That was one of the first questions we'd always ask our new hires. They'd get on our crew and we'd be like, go through the ambulance. So they'd go through it, they'd go through the bag, and we'd be like, where's the Broslo tape? I don't know. All right, let's go find it. So know where your resources are. Keep some on you. If you like to keep resources on you, or at least know where they're at. I like to just keep the little lifelike card with me that shows normal vital signs. And then I got the big one that Hoyt gave that has like ET sizes, doses, and all that. But do whatever's best for you. And continue being great. That's all I got. Gert.
Typical squad wants that.
Squad one.
You know, I confronted Christy. I was like, did you, because you don't remember how I would be in the whole program?
Yeah.
She was like, I put you with him to give everyone else a break. And I was like, so you punished me for being happy.
Sleepy boy?
Put it in.
Only two last night. 5 a.m. traffic accident.
That traffic accident was so cold. It was way colder than I was expecting.
Yeah, it was like 20 last night.
I know, but it felt like single digits.
I bet.
It was
humid,
chill,
too.
yeah.
It was humid last night. Shit to do. Cap, what do you need today?
Huh?
What do you need today?
Let's see.
Go get her.
You need to get them ambulances switched.
I think I'm gonna have one shortly. Sometime.
I think the school stuff. Start catching up on Canvas.
Okay.
And maps.
I'm in on that.
Are you falling behind?
Yeah, this is the same.
That's Rich coming from me, Brady.
She has a.
What do you mean falling behind?
He's
Johnny on the spot.
Sorry.
Exactly.
Other than writing emails, he's a little.
I mean, for like this week, I'm a little behind.
I'm more of a paper guy.
Nah.
I mean, they
You wrote a paper,
They're
give it
good,
to
huh?
me.
probably
Sorry, they can take the copy of the protein shake and breakfast.
He writes the email, then prints it, he
That was
doesn't
an
like that.
emergent marker.
Instead of saving the last email, that saves the 30 others as a row. Prints it one at a time.
It's so hard.
I didn't think I teach ropes, dude. Don't shoot us. How ropes?
I try and make it look like interactive.
Especially if we're not interactive.
I know.
We're writing papers in medical school.
So the answer is.
You're like T-balling us like questions and we're
Not
just
like
like.
paper.
Chief
You
Nance.
see, it's like, where's some conditions?
Oh, but that's.
Right.
We're writing like legitimate.
But okay, there you go.
Citations.
Oh, is that the new flavor?
We've done 3 presentations.
Yeah.
Yeah, that's alright.
I like it.
I promise at some point in your life.
Cannon sent me the funniest picture.
What you're learning right now?
I haven't
It'll be
like
good.
straight up like I was like made an audible. He's calling his dog's face back, so it's got like this like eyes placed there. It's my dog all the time, right? And then he goes, and then he sends it to me. And he
That's still
goes,
at the
"Hi,
end
I'm
of the day,
Corey. I
so
ski
that's
slow."
registered.
It's just a picture of his dog. And I was like,
Yeah, but
dude, it
you'll
was
come out, yeah.
so
You'll have
funny.
most of the stuff.
I'm so glad. I was dying.
I saw it, dude, and I was like, yeah,
Like
it's hilarious.
probably
Oh, I lost it.
eight.
I already skied this season.
Oh yeah, you did. Well, I
I mean, you
mean,
gotta do all your basic
you had
shit.
your
You
skis
haven't done any
on,
of that yet.
Skis.
but yeah.
I actually went to Alta.